Actually, when I look at this audience and think of ISPS, I have been involved with ISPS since 1988, and that was the first, in Turin was the first conference which I attended. And I think I found there what I would call a professional home for myself. It's such an unusual situation to have people from all around the world representing different psychological and psychosocial and psychotherapeutic interventions, talking together around sharing their ideas around a common subject, which is a psychosis. This context actually suits very well what we call the need-adapted care or the need-adapted approach. First of all, my affiliations here, as you notice, I am in many NGOs today, working in different boards on these. And I have to say, being on the board of the patients organization and family members organization has really opened my eyes in a different way once again, to see what it is like to be ill and what it is like to be a family member in this context. There's so much we as professionals don't really realize because we have this limited scope of view into the whole. Why did this happen at Turku? I think it's very important to sort of think about how did this kind of a development of the need-adapted approach, how did it ever come around? I think one of the main things is, of course, that you have to have interest, you have to have a place, you have to have a secure place to create and build something new. And this happened in Turku. First of all, I think it's very important to realize that Yrjö Alanen sort of made it possible. He provided an umbrella, protected us from the bad things, influences of the world, mainly administrative, which usually make development impossible for in the long run. And then he provided training, different kinds of training. He was himself a psychoanalyst and a family therapist. And even before him, at Turku, there was unusual interest in psychoanalytic thinking, and especially trying to work with severe health issues like psychosis. And then, because he was a university professor, he was interested in research, and he was interested in doing follow-up studies of what was the effectiveness of the approach we were using at different times. The training at the clinic was what I would call on-the-job training. So the staff was working there, and actually almost all of the staff got involved in the training in some way. The nurses, the psychologists, social workers, and doctors were all involved in the training. And I wrote, down there it says that we had a very low hierarchy. It really was so that I think that made also the development possible, that almost anybody could just raise an issue in a meeting and without having to worry about that, do I speak, what is the doctor going to think about when I say this, and is it okay to say something like this? It was very open, unusual. I think this idea came from milieu therapeutic thinking, which was applied also at that time. We were a university clinic, but we were on the front line, so all the first episode cases came to the clinic. It has been a long development, still in a way going on, where, as I told, the psychoanalytic thinking was the basis, but then came the family therapy in a very radical way. At the time, I got involved in this approach with the family movement. And I have to say that at the time, I almost believed that family therapy can cure everything. You just need an intervention and in the family, and then the family interaction changes in such a way that it's going to help the patient become well. Well, Then I had to do my research. I did a follow-up study and noticed it doesn't really work that way. So that you have to look at the whole in a very different way. The latest thing we started to get interested in was the biological side, use of medications. We did notice during the years that some patients manage with very low medications, so actually I'm talking about neuroleptic medication here, but actually without any. But it wasn't studied formally, and then we started a study formally in the late 1990s, and that showed the thing which is still present in the open dialogue, that there's a lot of patients that if there's a good psychosocial, family-oriented and individual supportive approach, you don't really need to use neuroleptics in the beginning, and then you can just see if there's some patients benefit from that and some don't. So you can choose really. And I think that's a very important part of thinking about any treatment. It needs to be need-adapted in that way. If you don't need something, you don't use it. If it doesn't help, you don't use it. You have to sort of follow up on what's going on. So actually, we did have a straight flush in the clinic at Turku. From top down, it was sort of more or less blowing the same way. And now we're going to the basic principles. It's very interesting. These were written around 1984, 83. And when I look at these, they are still up to date in many ways. Some of the wordings might be a little bit old, but still, these principles apply today as well as they did 40 years ago. The first one is very self-evident. I go to that, isn't it? It's always asked from us, what is a need? And a need is something which appears during the process. If you, for example, learn during the initial examination phase that the patient has been traumatized in his or her childhood, then you apply a different approach to that family and that patient. Or something else. If there's a history of problems in the family, or if you see that it's something in the family interaction which is a chronic situation, then you do work in a different way. So